There we go. Sorry about that.
That's okay. Okay, 675 clicks. We're here. So if there's any questions about my presentation, I just concluded my presentation. No? Okay. All right. First of all, Dr. Howe did an incredible job with beautiful illustrations. And it's something that actually probably run into a lot in pathology. Number one is like we end up with a diagnosis, and in the meantime, what's happening in the background, there's actually genetic testing that's going on, molecular testing that's going on. And I don't know about your institution, but our institution typically takes 3 weeks from the time you initiate genetic testing until you really get your results. In fact, I just got a text from a surgeon where I made a diagnosis of extraskeletal Ewing sarcoma in a pancreas in a 15-year-old girl that was supposed to be a solid pseudopapillary neoplasm of the pancreas. And I just got a text from him a few minutes ago saying it has the EWS Fly1, fusion associated with it. Guess what? The diagnosis was correct, although people are questioning it because they said, no, you don't get Ewing sarcoma extraskeletal in the pancreas. So oftentimes what we end up doing is we end up providing a diagnosis and later we get the genetic information. And so I think it's a really good illustration of, the clinician expecting to hopefully get a preliminary or near complete diagnosis with tissue that otherwise that we can take a look at, light microscopy, electron microscopy, and find that diagnosis, but later getting confirmation, of the diagnosis. So I'm just going to show you a couple cases with this. It's a little bit different than the abstract that I put in because that was more comprehensive. But on Friday, I'll be giving more comprehensive information on many different sort of pediatric diseases where electron microscopy is important. So this case is a fairly interesting one. This is a case scenario of a 2-year-old male. He was followed at a West Texas pediatric clinic for a chief complaint of foamy urine, eye and ankle swelling observed by the parents. And he had significant proteinuria, nephrotic range, edema. He had low albumin levels, hyperlipidemia, and also borderline hypertension. So a suspected diagnosis with this individual, especially in this age group with these findings, was minimal change disease, which is something that typically we do not get biopsies on because the clinicians treat that. It tends to improve, go away. And the only time that we get biopsies is when they actually do not improve and they question that diagnosis. Either we need to confirm the diagnosis, provide a different diagnosis. So he's treated for minimal change disease and there was no significant response, had several episodes of weaning the steroids off and still resistant nephrotic syndrome. And there's a concern, of course, for FSGS, even membranous GN, or other medical renal disease by the physician. I don't know if you've been in West Texas, but West Texas is a long way from most pediatric hospitals and pediatric nephrologists. And so when you're in West Texas, it's kind of a wild west out there as far as getting a diagnosis made and also getting tissue from these individuals. So he did undergo a renal biopsy out in sort of West Texas Hospital. The material was sent to us at our hospital, Texas Children's Hospital. And this is what the kidney biopsy looked like. And you can see the H&E on the left panel and the PA stain on the right panel. You can see that the background of this, there's no really chronicity to this. You can see that the tubules are back-to-back. Peritubular capillaries are really indistinct. And you can see that the glomeruli appearing to be appropriate in size. On the right-hand side, you see that there seem to be fairly prominent type of capillary lips out there, a little bit stiff looking, and a little bit extra sort of mesangial cells as well. And again, looking at this a little higher power, you can see it on left side, H&E, and on the right, the PA stain. And again, you can see that we have these very prominent type of capillary loops out there. We can see that mesangial cells are increased in general, and the matrix is increased as well. Looking at a few other sort of glomeruli here, and using the PS stain, again, we can see that we have mesangial cell increase overall. Capillary loops are open, which kind of speaks against it being segmental lesions in particular. But at this point, you're really concerned that perhaps you got a membranous disease that's going on with this particular patient. If you go on to the Jones stain, and just remember the Jones stain stained very nicely the membranes of the glomerulus as well as the membranes surrounding the tubules. And here we're starting to see areas where we see nice little areas with voids. And typically we see these voids, such as these areas here, going off into sort of mesangium here. And also you can see them out in the membranes as well, really nicely. Usually they associate those with deposits. And so this is probably the most common thing to see in membranous. And you can also see areas out here that kind of have that hair-in type of appearance that, again, we think that falls into sort of a membranous type pattern. And again, just showing you some more Jones stains, similar type of appearance throughout, really very membranous type of pattern. When you do a trichrome stain, this is the Gamori trichrome stain, so not a Masson's type of trichrome. But with this, you kind of get the feeling that maybe you do have something that looks like these little red deposits along the membranes, some very fine areas, very, very delicate look out in these regions here, as well as along this area. And here, perhaps even, if you use, quote, my imagination, you'll see that you can see what looks like little sort of red dots out here. So we're expecting that this is going to fall into a membranous nephritis type of pattern in general. So this are the immunofluorescent findings here. So it kind of speaks against not having IgG or C3. And so it kind of says what happened to our membranes and our membranous deposits. If we go on to the methylene blue, we use methylene blue staining for our semi-thick sections for light microscopy. You can see here, now we do have all these nice sort of clearings out in the membranes, and here in particular. And some of the mesangial areas, you also see similar type of areas with sort of that clear type of pattern associated with them. So if we go on to electron microscopy, this is what we see, fairly diffuse areas within the membranes. And you can see these areas where we have sort of clearing of the membranes, clear areas in here, like deposit-like areas, and then they have these little densities throughout. And this is true with every single type of membrane that you'll see there. We have these sort of cleared areas in here with densities in these areas. And within the mesangium, you also see a similar type of pattern, but with this particular case, it was very much more within the membranes. And again, showing you that again. And with this, you can also see within this area here, this is sort of going towards mesangium in these areas as well. And you can see that we have these kind of, quote, somewhat deposit-looking areas, clear areas in here with densities associated with those as well. Really don't see that within the podocytes. And I think there are a few areas where you can actually see foam cells in the background like these. And so you see a few foam cells in interstitial areas. And within the tubules themselves, these are more like protein resorption droplets rather than what you saw within the membranes. So I guess the question is, what's your diagnosis with this? So anyone want to give a diagnosis?
No cap deficiency.
Okay. Any other diagnosis? Two from the same person.
Syndrome.
Pardon?
Yeah.
Okay. So this is pretty typical. I said, if you want to get a opinion, you can send your case to three different pathologists and get 9 different opinions. So this is mesangial lipidosis with membranous type of pattern, or glomerular mesangial lipidosis. In this particular, this is a patient who previously didn't carry another diagnosis. So with this, we see this with Alagille syndrome. It's fairly rare type of situation, and we have several cases in sort of pediatric hospital. But with this, the next step really is, first of all, take a better look at the patient for the features associated with Alagille syndrome. And this patient actually had a Notch2 mutation, which is one of the rare type of mutations associated with Alagille syndrome. So with this, Alagille syndrome has 2 types of mutations associated with it. One is JAG1. This includes the jagged protein. It's a crucial cell surface ligand in the Notch signaling pathway, and it regulates cell fate decisions during development. The mutation causes multi-system type of disorder and affects the liver, the heart, and the skeleton, as well as the liver. And this is Alagille syndrome, and it's associated with cancer progression potentially as well. Notch2, it encodes a transmembrane receptor protein. It's critical in role controlling cell fate decisions, development, tissue repair, and this is particularly true in the heart, liver, and kidneys. And it acts as a receptor for JAG1, which JAG has up there, or Delta1. So it's sort of downstream from JAG in particular. And it's also, upon activation, it's an intercellular domain, moves to the nucleus, so it gets translocated to the nucleus, and it regulates gene expression. It regulates cell differentiation, proliferation, and also apoptosis, which is very important for sort of cancer development as well. So we look at developmental role. It's crucial for development before birth. If it's involved in the immune system function and causes bone remodeling, as we've seen in specific other syndrome that's listed here. And the disease association and mutation dysregulation Notch2 associated with Alagille syndrome. It's also associated with various cancers, including involving the liver, the bladder, B-cell lymphoma, and chronic lymphocytic leukemia. So if you look at Alagille syndrome, probably the more appropriate term for it is arteriohepatic dysplasia as terminology, but at this point, we don't add names to things anymore. In the past, we had names, and that has really stuck with this type of syndrome potentially. It's autosomal dominant inheritance, and it affects about 1 in 30,000 live births. Within the Houston area, we have about 7 million people, so we expect to see Alagilles off and on. And within the state of Texas, we have about 30 million people, so we see this reasonably frequently as far as Alagille syndrome. So the thing we typically see is the paucity of hepatic interlobular bile ducts associated with chronic cholestasis and high serum cholesterol and xanthomas. Within pediatrics, we have neonatal and infantile cholestatic liver disease, which involves a huge number of different types of etiologies. And with that, we have a molecular panel that includes about 30 to 60 different types of diseases associated with cholestatic liver disease. And this is one of the things that we do use to confirm syndromes such as Alagilles, such as progressive familial intrahepatic cholestasis diseases, which go up to about PFIC 10 or 11 at this point. Used to only be PFIC 4, so more and more are being discovered. So with Alagille syndrome, we have characteristic congenital heart defects, heart murmur, tetralogy of Fallot, pulmonary artery stenosis, ventricular atrial septal defects. Also, the skeletal abnormalities, the most classic thing is a butterfly vertebra, and this may be the first sign that the patient actually has Alagilles when they see a butterfly vertebra. And with the eye, you see these posterior embryotoxins that you can see as well. So the facial abnormalities are kind of interesting. You can see what's described here. And some people have described this as having what looks like sort of a French-type face. And of course, Alagille described this, and he is from France. And so all the features you see here tends to fit for that. To be honest, we have many children that do not have these faces, and perhaps it's because we don't have a very large French population in Houston. I'm not sure. So if you look at Alagille syndrome, if you want to provide the diagnosis without having the genetics done, in particular, if you have paucity of intrahepatic bile ducts, and you add 3 or more of the following to that, you can suspect that you have Alagille syndrome, which then you can go on to prove that with genetic testing as well. So chronic cholestasis, cardiac abnormalities, the posterior embryotoxin, the butterfly vertebra, and the characteristic facies. So if we look at Alagille syndrome from a standpoint of mutations, JAG1 mutations present about 97% of cases. You can see it's located on chromosome 20. There's more than 430 different mutations reported at this time. Notch2 receptor mutations in only 1 to 3% of cases, such as we saw in our particular cases, and the gene is located in 1p12. And there's at least 30 different mutations that have been reported with this as well. So with this, you can see that Notch2 is somewhat different than what you see with JAG1, with the features you see phenotypically. It has most of the features associated with what you see with JAG1, but with this, it has decreased cardiac involvement overall. Only 60% of Notch2 was 100% in JAG1 cohort. And also the vertebral vertebrae abnormalities only seen about 10% of Notch2 versus JAG1. And the facial features are less as well, supposedly in Notch2 versus JAG1. So not only do you see certain features that are sort of characteristic for Alagille syndrome in liver and other sites, but there are certain abnormalities in renal development that you see as well. Cystic kidney disease, kidney agenesis and hypogenesis, duplicate ureters, renal artery stenosis, horseshoe kidney, and tubular interstitial nephritis with glomerular changes. You don't see listed here the mesangial lipidoses. Typically, the findings we find Alagille syndrome, these are typical, which oftentimes we do not get kidney biopsies on these children, but mesangial lipidosis is one of the things you can see as glomerular type of findings. And as I've shown you there, you have these scattered sort of small lipid droplets, and typically you have this kind of retraction occurs with these electron dense areas that are clearing around those. So just to look at bioductility, so this is where your situation, you're looking for something that's not there. And so when you look at the portal regions, you really don't see bile ducts there. But interestingly, when you first get a biopsy on a Alagille's patient, they may have a certain number of bile ducts. So if you have less than 60%, you have 60% or greater portal areas with absence of bile ducts, that suggests that you do have Alagille's, and they can lose their others over a little bit of time. And here you can see that you really don't have any bile ducts associated with the portal regions. And the cytokeratin stain is just really highlighting what you get is sort of aberrant staining of cells in the background that are attempting to form bile ducts, but you actually don't form those. Oftentimes, within the second or third decade, sometimes even in the first decade, you undergo cirrhosis with paucity of the bile ducts, and you can see this very cholestatic type of liver with these dense kind of fibrotic areas within it. And typically, you're going to see cirrhosis in a fairly early onset with these individuals. So mesangial lipidosis and Alagille syndrome, it's been described as a classic glomerular lesion of Alagille syndrome, but it's not as well recognized as other features that you see in Alagille syndrome. And it's really been rarely reported in the literature as a predominant or only finding. So this is the first preliminary finding in this child who later had other features that went along with Alagille syndrome and had a genetic Notch2 mutation associated with it. So with this, it's speculated that in Alagille's patients with heavy proteinuria may have more predominant sort of GBM lipidosis, as you see in this particular patient, and less lipidosis in the mesangial cells in particular with this. So the other thing you have to consider, especially in a young child, is whether you really have Alagille syndrome, associated with mesangial lipidosis, or whether you have another type of situation, such as you see in LCAT deficiency. And LCAT deficiency is an autosomal recessive disease. There's a familial form. There's also a form that's called, which has complete absence of LCAT. You have one that's also a partial deficiency in LCAT called fisheye disease. And these have corneal opacities without the other associated renal disease. You can also have a secondary LCAT deficiency associated with autoimmune or acquired type of disease in particular. And the etiology, of course, is the lack of LCAT expression. And you see this in the defect associated with this. This is a rare entity, one about 1 million. We do see this on occasion at our institution. It's not very common. We really don't usually get the renal disease associated with that. Usually have the other features that you see, especially with the corneal type of changes. And you see the familial type of form has many different features associated with it, such as you see with cataracts, hemolytic anemia, and the proteinuria that brings early in childhood. And by the fourth decade of life, typically you're going to see progressive insufficiency there. With this, the diagnosis usually is based upon just low LCAT levels in the plasma. You can also see elevated serum lipoproteins associated with this. So typically, we're not going to get a kidney biopsy in individuals in general. But if you do get a kidney biopsy, you're going to see the same sort of mesangial lipidosis. You can also see in the background with progression of disease, tubular atrophy, interstitial fibrosis, and foam cells associated with it. So in a child, you want to think about not only Alagille's, but you want to think about LCAT deficiency as well. So one of our students that was at the learning to be a histotechnologist decided to spend a few weeks with us, and she actually got to the place where she's able to go through and scope some cases. This is a liver, and we thought this is really interesting. She came to us and said, I think this really represents something else. And so, so now we have Our Lady of Ultrastructure, courtesy of this person. And in the last month, she actually has joined our laboratory to become a EM technologist. And she has pretty exceptional skills, and I guess God is on her side. So the other thing I want to talk about, I think we got a few minutes left, is sort of a hairy sort of tail. And this is the role of scanning electron microscopy in diagnosis of hair shaft abnormalities. And this is something that I know that all of you are very interested in, and probably on a daily standpoint, get hairs sent to you through the mail. I do get hair sent through the mail as well as from our dermatology clinic. And sometimes it scares the people opening it because they open the thing, they see this thing just full of hair, and sometimes not too much hair. And so they just go, seriously, are you really going to look at this? Yes, I'm going to look at it. So with hair shaft abnormalities, you have acquired or congenital in nature. The clinical examinations you see, usually from a dermatologist, since they deal with nails and hair and skin, is like you have changes that occur in the color of the hair, the density of the hair, the length of the hair, loss of hair, hair falling out. And often you can have secondary structural alterations due to hair shaft abnormalities, such as, you see here. And with this, light microscopy can identify certain features that you can see with alternating light and dark bands. We call it tiger stripe pattern. This is really specific to a specific disease entity. And usually this is under a polarized light as well. But many of these are really difficult to identify just under light microscopy alone. And a lot of it, I think, requires a lot of imagination. So we started doing scanning electron microscopy for this several years ago and found it's really helpful in identifying the hair shaft abnormalities very readily and very easily. And of course, these hair shaft abnormalities may be the first sign of an underlying systemic type of disease or syndrome associated, which may require genetic evaluation. These are some of the differences, abnormalities you can see with hair shafts. I know that probably some people here deal with split ends. That's not really listed here, as you can see, but these are some of the entities that can be seen with hair shaft abnormalities. And with this, we probably see the majority of the ones that you see listed here. Light microscopy is fairly difficult to interpret with these as well. So if you look at disorders associated with hair shafts, now not every single hair shaft finding you're going to have is associated with disorder, but this is something you should always think about. You can see trichorexis nodosa, associated entities here, trichoschisis, trichorexis invaginata, monolith, pili, torti, woolly hair, curly hair, and also then a miscellaneous group below that. So these can all be associated with various systemic diseases. Some of these, of course, carrying genetic abnormalities associated with them, which are important for the child. These are also, you can have hair shaft disorders associated with fragility. And these are some of the ones where we have increased fragility associated with them, and some disorders that do not have increased fragility associated with them. So things such as someone who has breaking of their hair, very short hair in comparison to what they should have for longer hair. So one of the ones we're going to take a look at right away is pili trianguli at canaliculi. First of all, you have to realize dermatologists, what do they like? They like Latin. So almost all the terms you see here are in Latin. It's not simply, this is uncombable hair, and it's also called uncombable hair syndrome associated with this. And perhaps if you go back to some of the old collections of dolls from the early 1920s and 1950s, they used to have spun glass hair, which the hair kind of looked like this little girl here. And there's really great chance for people to go through and brush the hair and try to make it look sort of somewhat presentable. With this, basically, this is uncombable hair. So what you see is what you get. It's not going to change in any way. So this is characterized by longitudinal grooving of the hair shafts, and with the hair shafts having a triangular or heart-shaped appearance on a cross-section when you look at this. Of course, light microscopy, good luck looking at a cross-section light microscopy. Good luck seeing canaliculi on light microscopy as well. It requires a lot of imagination. So there are familial cases, and these are associated with autosomal dominant inheritance. And they can also have many associated abnormalities, including cataracts, abnormal bone development, alopecia areata, and lichen sclerosis. This is what this entity looks like. And as you can see, it has this fairly nice longitudinal groove that goes along the full length of the hair. This is responsible for the hair being uncombable, sort of that spun glass type of appearance. And if you look at a cross section, of course, you can imagine now it has a triangular shape to this indented area that has a heart shape appearance to it. So you can see with scanning electron microscopy, it's very easy to identify these. So the reason that this occurs is it's arising from premature keratinization of abnormally shaped dental papillae. It has asymmetric matrix defect, and it can be associated with the entities that you see here: ectodermal dysplasia, retinal dysplasia, juvenile cataracts, woolly hair nevus syndrome, and also atrophic eczema and nail abnormalities. The picture down below is a little girl that started off with fairly abundant type of hair and then went to this place where she went on to have uncombable hair. And this is one of the things that typically happens is early on, the child has very manageable hair, and as they get a little bit older, it becomes unmanageable, as you see in the picture there. It has almost this kind of like, just really bunches of hair out there. Pili torti, this is characteristic of hair shafts with twisting and flattening of the hair. The picture on the right there kind of looks like my brother decided he's going to cut my hair. And my mother then took me to a barber that actually took care of that, so it wasn't my brother's sort of haircut. Sometimes you get fractures along where the hair is twisting. Typically, it's a very unruly type of hair, including the eyebrows, eyelashes, and the scalp. And this can be associated with the things that you see here: non-progressive mental deficiency, sensorineural hearing loss, hypogonadism, ectodermal dysplasia, Menkes syndrome, and Gracil syndrome as well. And this is what pili torti looks like. You can see very nice sort of twisting of the hair, very nice. In some areas, it can be very flattened looking, and you can see it can become very, very tortuous overall. An example here, this is one of the ones that you can perhaps see on light microscopy, but scan electron microscopy really provides you a really nice illustrative type of appearance, and you can do this very quickly. It requires no preparation at all for the hair other than mounting it on a stub and looking at it and doing a cross-section in order to assess cross-sectional areas. So the classic pili torti has fragile eyebrow, eyelashes, and scalp, usually in the first 2 years of life. It can be autosomal dominant, autosomal recessive, or sporadic. If you have late onset pili torti, it's also associated with certain non-progressive mental deficiencies associated with that. And then there are syndromes that are associated with this too, such as you see here: Bornstadt with sensorineural hearing loss, Crandall syndrome with hypogonadism, and Gracil syndrome, which is growth retardation, aminoaciduria, cholestasis, iron overload, lactic acidosis, and early death. Also, you can see pili torti with ectodermal dysplasia. Of course, we realize that is a disease that has sweat gland absence associated with it. Menkes syndrome associated with this as well. You see the features listed here. And of course, Menkes syndrome associated with low serum copper and ceruloplasmin levels as well. Trichorexis nodosa, this is characterized by a sort of beaded nodal appearance along the hair shafts with fraying or fracturing of the hair shafts at these areas with this beading. It can be acquired, which has very curly hair, or genetic associated with these specific entities. This is what it looks like. So this is Trichorexis nodosa, and with electron microscopy, you can see very nicely illustrated that fracturing of those areas and overlapping between the hair shaft areas. So with this, these are the two different type of entities that are associated with this, and you can see the features associated with that. ASA is associated with urea synthesis inborn error, and at least the organ toxicity, neurological damages, seizures, and growth retardation. And also you can see that you can see a separate syndrome associated with that, with hyperammonia, low arginine. It has also dermatitis associated with it, rashes associated with it, and may have not only Trichorexis nodosa, but atrophic hairs and pili torti. This is what atrophic hairs look like. The hair on the bottom is a typical type of hair. The one on top, you can see very, very sort of thinning of the hair, has more of an atrophic appearance. And on cross-section, you see the diameter changes pretty markedly from what you expect for a normal hair. Trichoscresis, this is characterized by impending clean breaks in the hair shaft. This is associated with trichothiodystrophy, and this has very brittle hair associated with and very low sulfur as well. This is an autosomal recessive neuroectodermal disorder, and there's over 100 different variable features associated with this, with 8 different subgroups. And there are a couple of different sites where you can see actually impaired DNA synthesis associated with trichothiodystrophy. And this is the one that has this sort of tiger tail look to it on polarized light. And you can see the gastroschisis on the right hand there. With this, it has several different syndromes. So there's 8 different syndromes associated with this. Here are some here that are associated with trichothyroid dystrophy. And you can see some that have ichthyosis associated with it, otosclerosis, photosensitivity as well. Another form of hair shaft abnormality is bamboo type of hair. This is where you have hair that sort of invaginates along the hair shaft, an area that's getting ready to fracture. And you just see one portion of that looks kind of like a golf tee. We've lost the other portion that is fractured away. Associated with this, Netherton syndrome, and you can see the features associated with that, as well as hyper-IgE syndrome as well, associated with trichorexis invaginata. And this is what that looks like. You can see where the hair shaft sort of invaginates into the underlying piece of the hair shaft. This is a fracture site as well. And then there's loose anagen hair. Loose anagen hair is one of those where children actually, you can pull the hair and you can just pull hair out. And it gets very large loss of hair in particular. These lack the internal external root sheaths associated with this. These are harder to actually identify just on routine. Sort of looking at these with light microscopy, it really requires more of a actual biopsy. But you look at this from the hair shafts and find it's very easy to identify. So with this, they are not brittle. They have normal tensile strength associated with them. The hairs are not fractured. You don't have short hairs. You just have hairs that very easily are removed. And this is what it looks like. So it's like a hockey stick appearance. It's sort of a classic appearance associated with that. And oftentimes it'll have a linear groove associated with it as well. Woolly hair, as I should say here, very wide type of twisting to the hair axis. And you can see this in different familial recessive forms as well as other syndromes associated with woolly hair, as well as just a sporadic form. This is a situation where this patient had several different things that were present. You can see that the top here shows what's characteristic for loose anagen hair. You can see pili torti in here in particular. And this is where you get knotting of this area. This is just trichonodosa without the trichorexis. It's not fracture in particular. So utilization of scanning EM can rapidly identify abnormalities with many hair shaft abnormalities and allow for appropriate categorization. You can do this very quickly. You get the hair in your lab, and within 10 or 15 minutes, you're actually looking at it by scanning electron microscopy. We always go through and do polarized light on to make sure we don't have that sort of tiger tail appearance as well. And with this, you can actually help to evaluate for potential for doing genetic testing these individuals if they have other features that are concerning for something associated with the hair shaft abnormalities. So going back to Richmond, Virginia, perhaps you recognize the person who's shouting at this guy up on the. I'm not sure if you can recognize that person, but she was highlighted this morning. And this is getting ready to take the group picture. So I'm not sure this evening, taking the group picture, if we have anybody that's going to be on the ladder. But this individual can help you actually organize people with this. And I think she's very good at organizing. And here is actually the product. And the product turned out very well. And so within this, a few of you that were there back in 2010 at the Richmond meeting with Sarah Miller. Sarah organized that whole meeting and did an incredible job with organizing the meeting in Richmond, Virginia. So you probably recognize some of the people in the background, in particular, person who was chair here at USA for many years, Alan Tucker. I think you recognize this guy here. Probably recognize this woman. She's the lady who's shouting at the person up on the ladder. And I think Guillermo, Elba, I don't know, I'm up here somewhere. There's a guy there who's your president. And who else? A few other people mixed in here as well. So that concludes my talk. And if you have any questions, I'm happy to answer those for you.